Good morning, and thank you for inviting me to this very interesting Congress. I'm sorry not to be there, but I hope we will be effective also in this distant discussion. So, thank you for giving me the opportunity to discuss this very interesting topic, which is becoming more and more interesting in gynecological cancer. I will explain why. Ovarian cancer in particular is the big killer, as you know, among gynecological malignancies. And even though the incidence and mortality in the last year tend to decrease, still all our patients has an history of disease which is very similar to what you see in this picture. There is a first diagnosis with surgery and chemotherapy, then there is a remission period lasting 8 to 10 months, and then the disease reappear for more than 80% of ovarian patients. And the first recurrence, unfortunately, is only the first of several subsequent recurrences, typically treated with the chemotherapy and typically with a shorter time period between one recurrence and the other. That concludes with bowel obstruction. So the role of chemotherapy in the management of this we call chronic disease is of utmost importance, as you know, and the more the patient receive chemotherapy, the higher is the risk that we can face this secondary dysplasia for our patients. So the risk of ovarian cancer patient after chemo exposure has decreased over time. This is mainly due to the change in first-line treatment, and we move from other kind of alkylating agent to platinum, and the risk was decreasing. This is true for ovarian cancer, but also for multiple myeloma. But you know, it is not the same for non-Hodgkin lymphoma, for instance. In terms of relative contribution to the development of treatment-related disease, for sure, there are several identified risk factors, and most of them you will see are mainly present in ovarian cancer patients. We have a patient-specific risk factor. Age, for instance, this is a tumor of postmenopausal age, autoimmune disease, but also environmental exposure. Then we have a hereditable risk factor, and you know that up to 30% of ovarian cancer present a germline or somatic mutation in BRCA1, BRCA2 genes. But what is more interesting now is this new theory according to which stochastic mutation occur in an hematopoietic stem cell over time. But certain mutated gene provide a sort of fitness advantage in the context of various competitive conditions. And this competition filters for a mutant clone at the expense of healthy clone, resulting in a sort of clonal hematopoiesis of indeterminate potential, what we call CHIP. Over time, mutant clone can acquire additional mutation due to the mutation of DNA, particularly in patients who have an impairment in repairing DNA damage, as most of ovarian cancer patients, and this create a sort of regenerative hematopoiesis, which finally led in the evolution of tumor secondary leukemia, myelodysplastic syndrome, and myeloid leukemia. So this is the context, the etiopathogenic context that you know better than me, but this context play a major role in ovarian cancer. Since the beginning, we have a lot of information about that. Tumor-related myelodysplastic disease present very different characteristic with respect to de novo disease. In terms of age, for instance, this is a typical tumor of older age in terms of performance status and in terms of genomic characteristic of the tumor. And in particular, in ovarian cancer patients, what we see is a particular enrichment of TP53 and PPM1D gene, mutated genes in this kind of disease. Why this is so important? Because P53 is an inherent mechanism of BRCA mute patient. You know that almost 90% of high-grade serious tumor present P53 mutation, and all, I would say all BRCA mute tumor present P53 mutation. So this is a particularly enriched population with this mutation. But there is also another aspect. What we know over time is that BRCA mute represent 30% of ovarian cancer patients, but an additional 20% of ovarian cancer patients present mutation in HRD genes involved in homologous recombination deficiency, which confer genomic instability to the tumor and which are involved in DNA repair. So actually what we know is 1 out of 2 ovarian cancer patients present homologous recombination deficiency. And this will play a role also in the development of the disease. As you know, we can find 2 different types of therapy-related myeloid neoplasm. One is related to the alkylate. It's what we find in the treatment of patients with alkylating agent, including platinum, for instance, which is a typical syndrome with a long latency, up to 7 years, which present cytogenetic alteration in chromosome 5 and 7, which can be identified in more than 70% of therapy-related myeloid neoplasm. Typically, it presents with a myelodysplastic syndrome, and we can identify this syndrome in patients treated mainly with alkylating agent, and regarding our setting, patients treated with platinum. But there is also another huge group of myeloid neoplasm, which are related to topoisomerase 2 inhibitor. Typically, from a cytogenetic point of view, these are characterized by a translocation, but are less frequent, I have to say, about 30% of patients. Typically, they have a shorter latency, 2 or 3 years, no more, and the presentation is, in most part of cases, immediately characterized by an acute myeloid leukemia. We can find this kind of situation in patients receiving topoisomerase 2 inhibitor, but I want to remember that anthracycline are topoisomerase 2 inhibitor, and pegylated liposomal doxorubicin is part of our armamentarium in treating ovarian cancer patients. And since 25 years, it was evident that the use of platinum in terms of number of line, treatment duration, increase up to 4 times the risk of leukemia in ovarian cancer patients. But the risk related to chemotherapy was quite well known. What happened in the last year? We have the introduction, since 4 years ago, we have the introduction of a new class of agent, which is called PARP inhibitor. PARP inhibitors are of utmost importance. They change the natural history of ovarian cancer. These are drugs that for the first time increase overall survival in ovarian cancer since 20 years. Nevertheless, there are some issues. What is evident in first line, solo 1, Paula 1 trial, there is an increased risk, not significant according to the trial, but an increased risk of myelodysplastic syndrome and acute myeloid leukemia in patients treated with PARP in the range of 1 or 2%. But when we move at recurrence in patients who have received at least 2 or 3 times prior platinum, you see that the risk is much higher, up to 6 or 8% as reported in the long-term follow-up of SOLO2. It's why follow-up is so important, because the latency period, as you see, can be 5 to 7 years. So in first line, probably we have no enough longer follow-up to properly evaluate the final risk. In second line, when the follow-up is up to 6, 7 years, you see that the percentage rise up to 8%. So the problem is not negligible. Another important information that we saw from PARP inhibitor in second line is that the risk is much higher in patients with genetic predisposition. In the NOVA trial using niraparib, another PARP inhibitor in the maintenance setting of platinum-sensitive disease, G-BRCA patient present a risk up to 7% with respect to no G-BRCA patient less than 2%. All this information has been collected in a recently published meta-analysis reporting 18 trial and 10,000 patients. There were randomized trial, PARP versus placebo, and what we realize is that there is a PETO odds ratio of 2.63, so a significant increased risk in patients receiving PARP inhibitor. What are with the crude incidence of myelodysplastic syndrome and leukemia ranging between 0.73 and 1.22? What information we gained from this meta-analysis? That the median PARP treatment duration before of the diagnosis of secondary leukemia was around 10 months. The median latency period was around 18 months for myelodysplastic syndrome and less more than 20 months for acute leukemia. But surprisingly, it seems that PARP duration, type of drug use, BRCA or no BRCA, so biomarker specificity, treatment setting, second or first line, and number of prior systemic therapy does not impact the risk. I'm not so huge convinced about this meta-analysis, and the authors honestly say that the follow-up of the trial, of some of the trial, is not so long to draw definitive conclusion. PARP inhibitor, as I told you, are very important for gynecological malignancies, but they can be a double-edged sword because they impact on the capability of repairing DNA damage, and this is a good option when we talk about the incapability of repair DNA damage caused by chemotherapy, but this can be detrimental because if the damage is not repaired, secondary neoplasm can occur. And it's very interesting, in my opinion, this trial published by colleagues. We analyzed the patient enrolled in Ariel 2 and Ariel 3 trial. Both trials used a PARP inhibitor, rucaparib, in the maintenance setting of platinum-sensitive recurrent ovarian cancer patient. What is evident? It's the only trial that addressed the evaluation of disease before, evaluation of blood with the blood sample before and after treatment. And what the trial reported is that BRCA mute patients present an higher risk to develop myelodysplastic syndrome, but the syndrome was not driven by inherited predisposition. As you see, no difference in the incidence of secondary leukemia in patients who have germline or somatic mutation. Another important information that we raised from this trial is that the deleterious alteration in TP53, which was the most common CYP-associated variant in this cohort of patients, were significantly more frequent in patients that would develop TMN during or after treatment with rucaparib. As you see, 45% of patients present CHIP with the TP53 mutation in the group that unfortunately develop TMN with respect to 13% of patients in the control group. A secondary information, because we have longitudinal evaluation of this patient, is that it was very interesting to see about the clonal selection theory that all patients with the TP53 chip alteration before treatment or early during treatment experience a buff increase during treatment or at the end of the treatment, suggesting that it is an expansion on some pre-existing clones that contribute to the development of TMNs. And in this trial also it was reported again that the number of prior line of therapy impact the number and the duration of prior line of therapy impact significantly on the risk of developing the disease. Also, this trial confirmed that HRD alteration are a risk factor. 4.1% incidence of TMM in patients with BRCA, but also RAD mutation versus 1% in patients without impairment of homologous recombination. And also it was reported that the CHIP, TP53 CHIP correlated with platinum exposure with, so this represents a risk factor. It was evident since all this discussion that it can be that PARP create a selective pressure on the clonal expansion, and this study clearly reported that in patients treated with PARP, we have a selection of TP53 and PPM1D, which are both genes involved in homologous recombination in patients treated with PARP. And also in our institution, we have a similar expression. We analyze 300 patients treated, and we identify 13 myelodysplastic syndrome and acute myelodynia with an incidence of 4%. And in this patient, we perform NGS panel on bone marrow biopsy at the time of the development of disease, and in all these patients, we identify TP53 mutation, suggesting that this chip may be considered a significant factor to evaluate. So in conclusion, platinum-based chemo and PARP treatment increase the risk of therapy-related myeloid neoplasm in ovarian cancer. PARP-related disease are more frequent in the recurrent setting, probably because of the number of prior line of platinum. TP53 variants CHIP are associated with TMN during and following PARP treatment. And the idea is that the PARP may exert a selective pressure that boosts clonal expansion, particularly clones with the TP53 and PPM1D mutation, which are involved in the repair mechanism of the double-strand DNA. In this scenario, given that we cannot renounce to PARP, in my opinion, PARP should be used in first line, where the CHIP variants are probably less frequent because they have had less selection pressure because of less prior line of platinum, and possibly, according to the trial, the risk of TMM is lower. And this can increase, in my opinion, the benefit-risk ratio. Previous therapy, platinum in particular, may impact on TMM, and also genetic predisposition with homologous recombination deficient patient may have a role. What is evident from my point of view is that PARP inhibitor, again, bring to our attention a problem that we consider quite solved. but it is not the case. I think that this is a challenge for the future for hematologists and medical oncologists. I think that the future perspective, I would like to see future perspective trial clarifying the rule of CHIP, and if CHIP, TP53 mute CHIP, can be considered a reliable biomarker to select patient for PARP inhibitor, but also for modulate treatment. In this moment, we use PARP inhibitor for 2 or 3 years in the maintenance setting in first line. Probably, if this biomarker can be reliable, we can also consider to reduce the treatment, the duration of treatment in order to avoid this kind of problem. It will be very interesting to work on that on the future. Thank you so much for your attention.
I don't know if Professor Lorusso is online. There isn't. Okay. If somebody wants to comment, Maria Teresa, you want to comment the very interesting presentation, please use it.
I would have liked to ask, since TP53 is only rarely reported in the context of CHIP. This is one of the rare genes reported in the context of CHIP. So I was wondering whether ovarian cancer, which seem in this in all the papers that she presented, associated with CHIP in TP53, in the TP53 gene, what is, you know, the predisposing factor to that? She showed that BRCA1 mutations and RAD germline predispositions are present in this patient. So maybe there is an association between the germline predisposition and CHIP in TP53. Otherwise, I mean, the data on the frequent involvement of TP53 is different from what we are used to see in healthy donors. But this was my comment.
I also have a comment, but unfortunately, Ketta is not connected. But I found the presentation particularly clear and very informative. I wonder, given the high frequency of TMN in this patient population, whether we should establish what are the plans to establish surveillance programs for these patients in order to really anticipate the detection of clonal hematopoiesis, clonal expansion. I don't know how this is done in a routine fashion. I don't think this is done in a routine fashion, but it should be done in a routine fashion, especially for patients that present deleterious P53 mutations. But I don't think that there is here in the audience somebody involved in ovarian cancer that can answer this question.
Yeah. Well, I think, you know, those prevalence are similar to what we used to see in MOP-based regimen in Hodgkin lymphoma. And the result of that was that we abandoned MOP or intensified BCOP regimens in Hodgkin lymphoma to decrease the number of therapy-related TMN. So 5% is too much. So, but she said that, you know, we cannot avoid using PARP inhibitors in ovarian cancer. Maybe one strategy would be what she proposed in the last slide, to study by a myeloid panel the prevalence of CHIP in these patients, and maybe avoid PARP inhibitors, at least in those patients who have CHIP. This would be really a rational way to approach this.
Wonderful, but the cost will be dramatic in these cases, because if you try in all cases these tests at the end is impossible, considering the frequency of this kind of malignancy, unfortunately.
Yes, but since NGS costs are decreasing now, and so if we can provide NGS for for a limited amount of two, or maybe not 1,000 euro, but since costs are decreasing, maybe 5%, it's really too much, I think from our point of view, from a hematologist's point of view, I think 5%, it's a rate which is not acceptable, since these are TP53 mutated MDS or AML, which we know that these are the most difficult to treat. We don't have drugs against this. And, if the patient develops this complication, the life expectancy is 10% in 1 or 2 years. So, I mean, it's still a very severe complication.
Probably we must arrive to identify more easy with epidemiological studies, a very selected population that must be controlled highly.
It can be a topic for an application, for a grant application by a network organization that.
Yes, why not?